I'm Dr. Asma Malik. I practice general neurology and I specialize in movement disorders. That is my area of interest. And so I basically mostly see Parkinson's disease patients that make up the bulk of my patient population. So I am looking forward to discussing the role of botulinum toxin in Parkinson's disease and a brief overview of novel or latest emerging therapies. And I chose this topic because a lot of times my patients are also curious. So as am I on is there anything new out there, or what's going to happen, or is it still the old levodopa, which is, by the way, still our prototype medication. However, of course, there are other medications definitely that we can use, and botulinum toxin is something that I wanted to mention because a lot of times we don't get to learn much about that. So my objective of the talk would be to highlight the uses of botulinum toxin in Parkinson's disease and to shed light on the recent advances in the management of Parkinson's disease. I have no conflicts of interest to disclose for this topic. So, again, when you talk about botulinum toxin, the first thing that comes to mind are the cosmetic implications of Botox, because, and for the purposes of this talk, I'm just going to call it Botox, not botulinum toxin. It'll just be easier. So we think about the cosmetic implications because that is more widely known. But actually, if you delve into the history, botulinum toxin was first used by an ophthalmologist, Dr. Scott, for one of his patients to treat strabismus, which is called which is also malalignment, basically, of the eyes. And so it was used in 1979 for the first time. And it was discovered much earlier. The first time botulism was discovered was in the 1800s when a bunch of musicians was playing at a funeral and they consumed outdated meat. And from there on, it was discovered that it causes weakness and swallowing problems. So, and then later on, the thought was, okay, if it can cause weakness, then how can we use it for medical purposes? So it was really used by an ophthalmologist for the first time. So we do have a lot of implications of botulinum toxin. So how does it work? So how it works is, as the slide says over here, easiest to read it out, a message gets transmitted from the nerve to the muscle by the release of a chemical called acetylcholine from the nerve endings. So when botulinum toxin is injected into our muscle, it gets taken up by those nerve endings that interface with the muscle, and then it interferes with the release of acetylcholine, which is very important for the transmission of our nerve impulses and for our muscles to work. So basically, there is a break, an interference in that connection between the nerve and the muscle, and so the muscle weakens. So how do we use it for our Parkinson's patients? Well, we'll get to know next. Well, first, I'll just mention the types of the botulinum toxins. We have our Botox, that is the terminology I'm using more right now basically for this talk. Then we have other types called Xeomin, Dysport, a newer agent out there, FDA approved this year, called Daxxify, and then there is Myoblock. All right. So we use our Botox for different disorders in Parkinson's and in movement disorders. So in Parkinson's, some patients can suffer from dystonia. Some of us, you may have heard that terminology, dystonia. So what is dystonia? Dystonia, by definition, is a movement disorder characterized by sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. And so a lot of patients with Parkinson's can suffer from dystonia either prior to their diagnosis as part of their syndrome or as an aftermath of medications and treatment for Parkinson's disease. So some patients, when they take their levodopa, again, which is our main go-to medication, when they are on their medication, they may feel nice and loose, and when they are off their medication or wearing off, they can end up experiencing this dystonia. So they can acquire it as a result of our therapy as well. So it is seen in about 30% or more of patients suffering from Parkinson's, and sometimes can precede the overt Parkinsonism, which is our motor manifestation of the disease. And then, like the slide says, dystonia and Parkinsonism coexist in large number of neurological disorders, and dopamine plays a key role really in the pathogenesis of both dystonia and Parkinson's disease, and so dystonia itself can be part of the Parkinson's disease. And then the most common form of dystonia that we see in our Parkinson's patients is foot dystonia. A lot of patients come in with this upgoing toe, which is very bothersome. It can be painful as well, but there can be other forms of dystonia too. But a lot of times it's that foot or that big toe that's going up. So that is a picture, two pictures. So one is demonstrating foot dystonia. I don't know how big it is. So yeah, I think you should be able to see that toe, basically the great toe going up, that picture there. Cervical dystonia is also something that can happen. It is rarely seen as part of Parkinson's. It is an entity on its own, but it can also be seen as part of the Parkinson's. And these are just different kinds. In this picture, you can see the different types of cervical dystonia in patients. So the rotation of the neck is one of the most common forms of the dystonia that you see. Cervical dystonia, implies the neck. So these are different postures or abnormal positions of the neck that can be assumed by patients. Like it says, rotation or torticollis is the most common. So Botox can be an indication for this too. Blepharospasm. So what is blepharospasm? It is a focal meaning isolated, just specific to a site in the body. Cranial dystonia, cranial implying the upper portion of above our trunk, head and neck area basically. Focal cranial dystonia characterized by increased blinking and involuntary eyelid closure. Again, this can be an entity in itself, doesn't have to be part of Parkinson's, but we often do see this as part of Parkinson's disease. And then again, in patients who are on levodopa, they can also have it as a part of the syndrome of being treated and wearing off as well. Incidence of blepharospasm in Parkinson's has been reported between 0.9% and 3.26% according to certain literatures. May rarely precede the disease and can be levodopa responsive as well. So it doesn't always have to be wearing off from the levodopa. Some of these dystonias can be responsive to levodopa too. So the management of Parkinson's, as most of you know, and these slides imply, it ends up being a lot of tweaking of medications by the clinician. At times it could be an on phenomena, at times it can be an off phenomenon. Excessive salivation. A lot of patients get surprised when I talk about the implication of Botox for that excessive salivation or drooling that patients develop. It's actually been used very successfully in the treatment of drooling for Parkinson's. And usually the kind of botulinum toxin I prefer to use is called Myoblock. It has been shown to be more useful in the treatment of the excessive salivation, or what we call siluria. And these are the certain locations where we can inject our patients. And my favorite place is just the one right next to the ear, the parotid glands. It is easily accessible. And for most patients, I would say about 70-80% patients, just injecting the parotid glands is useful and it's successful. So don't have to end up injecting the ones underneath, like the next, like in the neck area, which are our sublingual and the submandibular glands, which can be injected too, of course. And then tremor. Tremor is defined by the Movement Disorder Society and by other experts out there as a rhythmic oscillatory movement, regular rhythmic oscillatory movement, where in certain patients it can be more jerky. It doesn't have to always follow that. It's not set in stone. It doesn't always have to follow that rule. But then, as you can imagine, tremor is a sum total or a result of the movement of different muscles working in concert to cause that tremor. And so treating tremor with botulinum toxin can be challenging because botulinum toxin is supposed to, the expert has to be able to inject just the right muscles. So with the tremor, it can be a little challenging. However, people with specific tremors, which we call task-specific tremors or positional tremors, those patients can really benefit immensely from the botulinum toxin. So it can be used to treat tremor, although choosing the ideal location for injections can be challenging, and benefit has to date not been very encouraging. However, there are experts out there that do successfully treat the tremors with Botox. Before I switch gears here, of course, with the botulinum toxin, some stuff that is missing from the slides is that when we do the Botox, or like I said, I would use the term Botox. When we do use Botox, we also use, some of you may have seen, a little machine to kind of guide us to inject. So that is another thing that we use to help guide treatment, as well as, of course, our knowledge of anatomy. Some clinicians also use an ultrasound to guide us to do to be able to do or administer Botox in the correct areas. So we do that too. And then botulinum toxin, also patients wonder right out after the injection, am I going to feel better once I go home? Well, no, it can take up to 5 to 6 days or so, average plus minus, to kind of take effect, and usually peaks in about 6 weeks, and then it starts to die down. So the peak effective is in about 6 weeks. Side effects, as you can imagine, since it's causing weakening of the muscles, it can cause excessive weakening of the muscles. There can be swallowing issues. Again, all that can be prevented by being very specific about the location. And also, at least I usually start out low and slow. However, one has to be able to dose it according to the patient and what they are suffering from. So I will switch gears here and just briefly mention some advances in the treatment. So Crexont was approved just 2 months ago in August of 2024. Again, it is an extended release carbidopa levodopa, so nothing hugely different. However, this medication was shown to help with the help increase the on time for our Parkinson's patients and also reduce that off time. And so the fluctuations that certain patients experience when they take the immediate release carbidopa levodopa, this was shown to be more helpful. This graph here compares immediate release carbidopa levodopa that I personally love starting out my patients on, and it works beautifully. But then it compares that with the another extended release formulation, Rytary, which is being marketed by the same pharmaceutical company, Amneal, and then Crexont. So it's out there. I haven't tried it as yet. It was just approved. We don't have it as yet in our pharmacy as yet. So waiting, fingers crossed. Next slide. Subcutaneous infusion of carbidopa levodopa. It's been out there being practiced in Europe for a while now, and it's very promising, and I'm hoping that it will get approved in the United States soon enough, because that should really help alleviate a lot of issues for patients who have trouble swallowing and for that oral absorption of levodopa. It's supposed to be just subcutaneous, so it should be able to, it should be very useful. So I'm looking forward to that. There are 2 different formulations that are available, at least in Europe. This I just threw in there. I found it very interesting that we often ignore that levodopa can also have a long duration response. So just to bear in mind, there was a study showing that that the levodopa has an effect on neuroplasticity as well. And so there was a study which was a 15-day treatment duration, and they had some neurophysiological markers, we call them, before and after treatment with levodopa. And so there were patients who were made to do some learned motor activity or exercises, and then they were studied before treatment with levodopa and after treatment with levodopa. And And so that the response was measured, and it was shown to be very encouraging that levodopa could have actually in long term an encouraging and a positive effect as well. So starting levodopa earlier in the course of the disease is actually something that is presently encouraged by movement disorder physicians. LRRK2 inhibition in Parkinson's disease, this is one of those medications in pipeline. It has been worked on for years now. LRRK2 is one of the genetic most common autosomal dominant, meaning that it's just dominant through heritage in the families, mutation in Parkinson's disease. Now, one has to bear in mind, to date, according to literature, only 5% of Parkinson's disease has a genetic link. However, we are finding more and more that there is a family history. There is an association of a strong family history with Parkinson's too. So there is more that is being discovered at present. And actually, the discoveries have kind of shot, as in it's rapidly changing. So with all the AI and all the latest technology we have out there. But anyhow, LRRK2 there's so mutations in the LRRK2 gene, leucine-rich repeat kinase 2, they are a common cause of autosomal dominant Parkinson's disease. And so inhibitors of LRRK2 correct lysosomal dysfunction. Lysosomes are organelles inside our cells that help clear waste products. So when there is there is a strong link of lysosomal dysfunction with Parkinson's disease, so LRRK2 inhibitors are thought to correct lysosomal dysfunction and thought to block downstream neurodegeneration. And even in patients without that the genetic mutation, those patients are thought to, there's a thought that they could benefit from the LRRK2 inhibition. Prasinezumab in early Parkinson's disease, as you may have heard or some of you already know, that the pathology of Parkinson's is this abnormal aggregation of a protein called alpha-synuclein. And so prasinezumab is a monoclonal. It's an antibody that binds this aggregation of alpha-synuclein and helps clear the alpha-synuclein away. Now, these studies with these monoclonal antibodies have been going on for years and years. And in Alzheimer's, we have had very promising results with the anti-amyloid therapy. So we are hoping that this will also yield good results, and we should be able to slow down the progression of the motor symptoms of the disease and also slow down the progression of the disease itself. And I'll read the third line. In a trial of 1 year duration, prasinezumab might reduce motor progression to a greater extent in individuals with more rapidly progressing Parkinson's disease. So the diabetes drug, some patients have even questioned that, like, what about the diabetes drug? It's very interesting. The studies on diabetes drugs have been done before as well. Previously, to one of the medications called exenatide, there was a study on that as well. And not just a study, there have been multiple studies, and it was shown to be promising in the treatment of Parkinson's. So these are GLP-1 agonists. These are how glucagon-like peptide-1 agonists. And so exenatide is the one that has been most recently worked on and studied on. It reduced motor disability progression in patients with early Parkinson's disease, suggesting a disease-modifying effect. Of course, it warrants further investigations, larger trials. It is not available as it is still being studied. So, so let's see what patients who are on this medication, how they do. Focused ultrasound has been out there now for a few years. 2018, the FDA approved focal ultrasound for Parkinson's tremor. And in 2021, it gained an expansion of FDA approval to include other Parkinson's symptoms too. And then how it works, briefly, in a nutshell, lesions are produced by the focusing of hundreds of ultrasound beams in a selected brain region. And so in doing so, that energy of ultrasound is converted into a temperature, the increase of temperature, and then that's the mechanism by which the ultrasound energy will produce ablation, basically a burn in that area of the brain that is abnormal in Parkinson's disease. And so the clinical effects of ultrasound can be immediate. They can last up to 5 years. Of course, long-term follow-ups are still needed to see how long it works and how many times patients would need more therapies. And thank you.